Things which I have to remember in the supracondylar fractures of children is that um, mostly they are classified as flexion type or extension type. The flexion type are least common one, and extension type are 98% of incidence. The extension in extension type, they are classified as per Gartland. Type 1 is undisplaced fracture. Type 2 is the one in which the posterior cortex is intact. Type 3 is when there is the periosteum is intact, and type 4 is the one in which the periosteum is also disrupted. Um, on clinical assessment, if I see the patient in AME, I would like to take an optimal history of the patient, do a clinical assessment, check the neurology, and check the pulsations. In the neurology, I would assess for radial nerve, ulnar nerve, and median nerve. The ulnar nerve can be assessed or abduction, adduction of the fingers. The median nerve can be checked by an OK sign, and the radial nerve with the wrist extension and the finger extension itself. The most common injury is the anterior interosseous nerve, which happens in the in the extension type of injury, which is most common. In the flexion type, the common nerve involved is the ulnar nerve. Checking the neurovascular status is important. I will place the patient in position of comfort. This is and give adequate analgesia along with the back slab application. Any supracondylar fracture should be managed as per the BOST guidelines, which states that any impending vascular compromise should go for operative intervention as soon as possible. Impending vascular compromise means that there is no pulsations, but capillary fill is okay. In such incidents, I would have a high predilection to have a vascular opinion. Um, um, Anyhow, any vascular injury which happens, the first foremost thing is to reduce the fracture. I will book the patient for theater. Uh, if this patient comes in at overnight, if the patient has impending vascular compromise, as per the BOST guidelines, these should be treated as emergency. I would have a low threshold for going on for operative intervention instead of delaying. The reason being, first, the reduction is easier as earlier as possible. And second is that as there is impending vascular compromise, we are not sure whether the vessel is being kinked or there is an internal injury. So while in theater, after adequate anesthesia, I would not in the beginning I will apply a tourniquet, but I will not inflate it. I will do a manual traction and maintain the length first. Once I have maintained the length, then I will assess the under image intensification and assess the corneal deformity and correct it with the thumb and the index finger. Once I have corrected it, I would flex the elbow and mostly pronate it. The rule of thumb is important. If there is a posterior medial deformity, then as there is a posterior medial deformity, a pronation position will lock the fracture. If there is a posterolateral deformity, which is rare, posterolateral comminution, which is rare, then I would have to supinate the hand. Anyhow, sometimes the fracture does not read the book itself, and sometimes I have to attempt both of them. And after the reduction, I will take a Jones view of the patient. In Jones view, I will assess the medial and lateral margins of the distal surface of the supracondylar region and check if the ridges are intact. Moreover, I would like to do a lateral view as well with movement of the elbow and movement of the forearm and the arm um, in along with each other. After assessing the X-ray, I would prefer to do two lateral K-wires. I can understand the controversy between the lateral K-wire or isolated lateral 2 K-wires or the lateral and medial cross K-wires. As per the Skag et al., the lateral 2K wires are almost stable enough when compared to the cross wires. Uh, but biomechanically, the torsion forces or rotation translation forces, the cross wires are better. Regarding the impending vascular compromise, there was a study by Scannell which showed that these patients, which were prospectively followed for 20 months, showed no problem with pulsations and no problem with the growth itself. So if I was able to reduce this fracture with lateral 2K wires, my principle on lateral 2K wires would be that the K wires should be crossing through the distal fragment as well as the proximal fragment. They should be divergent at the end and there should be bicortical, both K wires. Then after doing 2K wires, I will assess the patient and check for stability. If it's stable, I would prefer to put a back slab. If it's unstable, I would have a low threshold to put a third K wire. If anyhow I would need to have medial K wire, I would prefer to do it with the open technique, with a mini open incision at the medial epicondyle. I will give an incision, use an artery forceps to identify the bone, avoiding the ulnar nerve and using the thumb to displace the ulnar nerve posteriorly and place a wire.